Hi Jerry, welcome to ERC in the Field session. How are you doing, Jerry?
Hi Nicholas, yeah, very well, thank you very much. I have a well-earned day off today.
Okay, so I understand you're working in Bath in UK, that's right?
Yeah, that's right. I work at the Royal United Hospital in Bath in the UK, so that's in the south of the UK. It's about a 700 bed sort of very standard general hospital, really.
Okay, so what's your function in the hospital, Jerry?
So I'm a consultant in anaesthesia and intensive care, and it's actually very common in the UK. Probably 80% of critical care doctors are dual accredited in anaesthesia and intensive care. So I spend about half my clinical time in anaesthesia and half in critical care. Although, of course, with the COVID-19 pandemic, it's been all working in critical care, as of course most of the anaesthetists have as well.
Okay, what changed in your hospital? How did you prepare for this pandemic, Jerry?
Well, I've got to give a lot of credit to my the sort of clinical lead for intensive care here in Bath, Dr. Andy Giorgio. He's a colleague who's worked really hard along with the lead nurses, really putting together a plan to deal with what we thought was going to be a pretty substantial surge in COVID-19 cases. And of course, that was based on the experience from Italy. One of the interesting aspects of this disease and this crisis, if you like, is the fact that most countries, apart from, I suspect, Northern Italy, have been given a fair amount of warning about this. And so you could pre-plan and make major changes even to the structure of the hospital as well as to the way it worked. For a variety of reasons, we chose to, right from the outset, convert our day surgery operating rooms into what would become the COVID-19 ITU. And by doing that, well, there was two main reasons. One is that we could much easier control for infection by doing that, because we only have a few side rooms on our main ICU. And infection control would have been more difficult. Whereas operating theatres, strangely, because we also operate with anaesthetic rooms, as well as scrub rooms as well. So each of these operating theatres can accommodate 2 critically ill patients. And you can then have a donning and a doffing room. And you can actually infection control extremely well by doing that. And so we chose to do that. So most of our COVID-19 patients have been looked after in the operating theatre right from the beginning.
Okay, so in terms of capacity, was that sufficient to treat all patients, or did you face at any time difficulties to care for the patients?
Well, interestingly, and I suspect this is true in most countries, the effects of COVID-19 have been felt very differently in different regions. So the short answer to your question is actually we were able to accommodate our patients so far. And whenever I say this, I'm hesitant because we are informed that we could get an even bigger second wave, as it were. But for the time being, we could accommodate potentially. We only have normally a 13-bed ICU, and it's typical, as most people are aware, for the UK to have almost the fewest number of ICU beds per population compared with any other country. And certainly, it's 4 times fewer than, say, Germany. So we started with 13 beds. We created the equivalent of another 13 beds in the day surgery operating rooms. And then at the same time, we're actually converting one of the wards into an ICU. Strangely enough, because the plan was already in place to do that many months ago, and all we did was accelerate it. So they've completely converted a ward into a full ICU, including with negative pressure rooms, in 6 weeks. And we are due to move into that tomorrow. So we will then have 2 ICUs and potentially the operating theatres as well. So we would be able to accommodate up to 40 patients ventilated. Okay. We haven't had to do anything like that amount for COVID. I suspect the highest number of COVID patients in our hospital in critical care at any one time has been about 12 or 13, with something like maybe 60 in the hospital altogether at any one time.
Okay, so that's probably comparable to most hospital. Were there any other issues or problems you faced well during preparation or during care of the patients?
Well, I think the other area of planning is what you can see behind me in the background here. This actually is the emergency department, and initially there were no negative pressure rooms in our emergency department, and this was an area that was being an empty area that was going to be used for something else, and was very rapidly converted to having 4 negative pressure rooms for intubation of COVID patients that were arriving in the hospital. So that was another structural change that we undertook. And then as far as personnel, and I think this must be true of almost any country in the world possibly, of course, all doctors were repurposed, the term we use, where they're put onto different rotas and doing different tasks. Many of the surgeons couldn't operate, so they've been doing different things. And of course, a lot of and if not all of the anaesthetists have been reassigned to roles that either are within the ICU or are supporting us. And we have these so-called merit teams, these intubation teams. So they will go and intubate a patient and then transfer them to the ICU, which relieves the pressure from us, the ICU doctors, from having to do that. So it's a good way, I think, of sharing the workload. And it's a really good example where the fact you've got anaesthetists who are very highly trained in critical care as well. As I say, most of our intensivists are dual trained anyway. So it's really very easy for them to convert across, and they're really quite knowledgeable about looking after critically ill patients.
Okay, so actually they came to the emergency department as an
So in the UK, again, I guess I should probably explain that. So of course we do have a very well developed emergency medicine specialty with its own college, etc. But one thing that's still fairly common is that they will often not be involved in things like intubation. It varies from hospital to hospital and from individual emergency physician to another one. But in general, they don't do that many intubations. So even in the non-pandemic scenario, anaesthetists and intensive care doctors support the emergency physicians down there. And we work very well and very collaboratively as a team, as we continue to do in the crisis.
Okay, Jerry. With regard to resuscitation, did you take specific measures to reorganize your usual teams? How did that went?
Yes, I think the most important thing, of course, relates to PPE and its availability. The standard approach for our hospital, much like many of the UK hospitals, is that in the event of a cardiac arrest, a 222 call is made, and then the resuscitation team will obviously rapidly go to the ward or wherever the patient's arrested. That team, importantly, always includes one of the ICU resident doctors, and then there will be general medical doctors as well as various nurses, etc. The time of COVID-19, the important thing was to try and ensure that the resuscitation team would be properly equipped with personal protective equipment, and more importantly, the airborne precaution PPE. So they would need to have an FFP3 mask or equivalent, long sleeve fluid repellent gown, visors, gloves. And the difficulty is, like many countries, we're facing limited supplies of PPE at that level. So a decision was made that the ICU resident would always carry airborne PPE with the resuscitation bag, so they would know that they at least had it themselves. And then we have resuscitation trolleys, as we call them, in each of the ward areas, each of the clinical areas of the hospital. And we made sure there was one set of PPE, so full airborne PPE on that trolley as well. So we, just like the ERC guidelines suggest, will allow staff to at least apply defibrillation patches and use an AED or defibrillator as appropriate, using standard droplet precaution PPE. So that would just be a surgical mask, an apron and gloves. And then they can at least give a shock if it's a shock or rhythm. In the meantime, the resuscitation team would arrive and they would don the full airborne precaution PPE, and they could then take over with chest compressions and airway interventions, etc. And it seems now that that's worked very well. Initially, we said that would only be necessary for confirmed or suspected COVID-19 patients. But I think, like many places in the world, you very quickly realise that it's pretty difficult to spot those that are really COVID-19, partly because they may not have been tested yet, or the results may not be back. Or, of course, I think many of us are recognising a significant proportion of false negative results from those tests. So in recent days, every cardiac arrest call now has assumed it could be a COVID positive patient. And so those PPE precautions are applying to all cardiac arrests. And I think the staff are comfortable with that approach. There is no doubt that on occasions there's a very small delay in delivery of chest compressions. And yes, that is a concern. But I think overall we have to take safety of the healthcare professionals as the most important thing.
Okay. Well, thank you very much, Jerry, for sharing your experience with us, and then for taking the time in this busy schedule to be with us. Thank you very much, Jerry.
Not at all. Thanks, Nicholas. It's a pleasure.